So first of all, generally speaking, my idea for the talk is that we're not going to really talk much about what chemotherapy you can do or how you do the chemotherapy. I'm going to focus more on when you do chemotherapy, because I think from the point of view of what we have, we've all got the same drugs available to us. How we do it, we can all give an IV injection or a tablet. So that's not really the difficult part. The difficult bit probably is more deciding when we do it, which patients are going to do best with chemotherapy, which patients is it a bit of a long shot. So that's really my plan, I suppose, generally for where we're going to go with this. So I suppose the number one, I'm trying to guess what my next slide is because I can't see it. The number one thing, or the number one disease that I would say we're going to be treating with chemotherapy is lymphoma. Okay, and I think from the point of view of if you're going to have cases of lymphoma coming into your practice, the only treatment that you can give them really is chemotherapy. Okay, so whether that's chemotherapy in the form of just steroids or whether it's chemotherapy in the form of actual cytotoxic drugs, they're not going to do well without something medically. Okay, well, let's think about this a bit more. So we've got 4 different options there for chemotherapy. So we've got CHOP, and these are studies that we're looking at CHOP treatment. So that's cyclophosphamide, vincristine, prednisolone, and doxorubicin. Okay, we've got a couple on the top row there. Multicentric, your typical sort of dog that comes in with big lymph nodes. Undefined location just means that in the study they maybe had other sites, so they maybe had some hepatic ones or they maybe had some renal ones or whatever. You've got COP, which is just your cyclophosphamide, vincristine and pred, and that's just a mixed bag of whatever dogs they had. And then you've got at the bottom doxorubicin only as a treatment. Now, basically we've got a range, so for the top line you've got between 73 days survival and 622 days survival, with the median, so the halfway point being 267. And then you can basically see that for the 4 different chemo options there, they're much of a muchness. I mean, okay, the CHOP ones, you've got a little bit longer at the end there. They're going to last perhaps a little bit better, but between 80 and 400 days, as a sort of a rough guide. Now, if we don't give these guys any chemo, they're going to die, well, I don't know, 6 weeks, 8 weeks. Maybe if they're on preds, they're going to get a couple of months. But we're seeing really significant lengths of time that we can give them with good quality of life with chemotherapy. Okay, and it doesn't have to be CHOP. You could just give them doxorubicin. Single drug, 1 drug to think about, and a living median of 230 days. So, long-term survival, just to try and put this into a little bit more, a slightly different context, CHOP treatments, and again, they vary because there's different studies, but basically, if we look at the first one, because that's the multicentric one, which is going to be the more typical dog that comes in with lots of big lymph nodes, you've got a 1-year survival between 28 and 70%. 2 years up to 33%, 3-year survival up to 25% of cases. Now that's pretty good. When you talk about these dogs that are going to die in a couple of months if they don't have anything. Okay, I'm seeing a dog tomorrow for a recheck that in July, so now, it's 3 years since we first saw her for chemo. Okay, so it's not unusual, and I think that's something that's worth emphasizing. The COP, the COP, is slightly worse, but you're still getting a certain number of dogs potentially that are going to have 2 or 3 year survival. Okay, so I think it's worth being aware of that. Although the median survival might just be, 9 months a year, you're definitely getting some of these dogs that go on and do well. And certainly I've had dogs that have effectively been cured of lymphoma, where the owners phone you up at 5 years and say, oh, such and such is still quite happy and well. So it does happen. Now, I never tell an owner that it's going to be cured. They don't know that, but it's nice when it happens, and it can happen. And we don't really know when it happens, so you can't predict it. So, prognostic factors, and this is the thing that I think is also worth considering. The ones in yellow are the only really convincing things that are prognostic for both remission and survival for chemo in lymphoma. Okay, so response to treatment is a tricky one because you're not going to know if it responds to treatment until you try treating it, but effectively that is the point, is that the dogs that respond well to treatment will do better, which is sort of obvious, but it means that if you want to know if it's going to work, you've got to try at least. Okay? Immunophenotype is basically where you're looking at either B cell or T cell, and as has always been sort of suggested, B cell dogs do tend to do better on the whole. Okay, now that's not to say that T cell is always bad, and I would still always try and treat them, but on the whole, if you've got a B cell immunophenotype, it is likely to have a better outcome. All these other things don't matter. Okay, so I have quite a lot of people contacting me saying, oh, the dog's been on steroids, or I want to put the dog on something, but I can't give it on steroids because it'll affect it. Yeah, it's not really that evidence-based. And certainly if you've got a dog with a lymphoma and it's got to wait a couple of weeks to get chemo, there's no issue with sticking it on steroids to make it feel better for a couple of weeks. Okay, it's not going to have a massive impact on whether it lives a year or 2 years or 3 years. Okay, hypercalcemia, again, not really convincingly bad. It is a little bit more of a likelihood that you have hypercalcemia with T-cell disease, so maybe that's, you know, possibly a bit more important, but on its own, it doesn't seem to be a factor. And clinical stage doesn't really make a lot of difference. So spending a lot of money on your lymphoma dog to say, well, we're going to scan its abdomen and we're going to bone marrow aspirate it and we're going to do all these other x-rays and things, we'll spend a lot of money, but it won't change whether or not it's going to respond to chemo. Okay, so from my point of view, if we have a dog come in, as long as I know it's lymphoma, and usually what we do is cytology and flow on the lymph node aspirates, we'll get an immunophenotype, you'll get your confirmation of lymphoma. As long as its hematology is normal and it doesn't look like it's got leukemia or something, then I don't tend to be that bothered about doing ultrasounds, doing x-rays, doing aspirates for bone marrow. If you do want to do a bone marrow aspirate, just going slightly off the point, the simplest option is to get a hypodermic needle and stick it into the end of a rib, and then just suck out a little bit of bone marrow from the end of its rib, and it saves you using a fancy bone marrow needle and trying to stick it into its hip or something. And generally that works pretty well, actually. You just sort of find where the rib attaches to the wee cartilage bit and green needle, and you can get a little bone marrow aspirate. But as I say, you don't need it, so that's pointless. Okay, now, I don't know what my next slide is. What else should we treat? Right, okay, so that's lymphoma. So basically, what I would say is if you're going to do no other chemotherapy, I would say you should be thinking about giving dogs with lymphoma chemo. Okay, because they're the dogs that will definitely, or not definitely, 90% of the time respond to it. They'll have a good quality of life for a lot longer than what you would otherwise get if you're saying, well, no, we're not going to treat it. Okay, so that would be my first plug. What else should we treat? So what else do you treat? Does anybody give chemotherapy for something else other than lymphoma? But yes, okay, so survey of the UK general practicing vets. Okay, now, so we've got splenic hemangiosarcoma, which they've abbreviated to SHS, and appendicular osteosarc, which is AOS. So 40 to 57% of, 40% for hemangiosarcoma, 57% for osteosarc said that they would recommend treatment. So about half or whatever said, yes, we would recommend some treatment. And of those, an appropriate chemotherapy wasn't known by 51 and 36%. And from those not recommending it, most of the ones that weren't recommending it thought that there wasn't any effective chemo. Okay, so I suppose what I'm trying to say is that there's quite a common reluctance to give chemo to these two sets of dogs. Not many people perhaps know about chemo options for them, or if they do have an idea about chemo, they don't think that it's going to work. So we're going to start with osteosarcoma. Now, from a treatment point of view, obviously amputation is a quick way to take away the pain. And for most dogs, is probably a reasonable option. Obviously, you're going to get some dogs that aren't suitable for whatever reason, whether they've got, other leg problems. Tell I'm not an orthopedic surgeon. But generally speaking, if you've got an osteosarcoma, chop its leg off, the dog will feel better. But will it live very long? So, amputation only, we reckon about 138 days. So what's that? 4 or 5 months. Okay, which is okay. It's reasonable. But if we give it some chemo, then it's going to double that. Okay, now 4 doses of carboplatin, you're giving them every 3 weeks, so you're talking about 12 weeks of treatment. Well, 1, 4, 8, 12. Yeah, 4, 8, 12. Hang on, I can't do the maths. What did I just say? 3, 6, 9. So yeah, 9 weeks. Look at that, even better, right? 9 weeks of chemo to buy you another 6 months of life. Right, that sounds like a reasonable option. Doxorubicin, 5 doses, so slightly longer. But I mean, that's again, it's every 3 weeks. So 12 weeks for doxorubicin. Okay? And the idea is that that quality is good. Yeah, so whatever we're doing, whenever we're giving the chemo, we're aiming for good quality of life. But it's a reasonable difference. I would argue it's a significant difference in the lifespan for that dog for a relatively short period of medication. Okay. Hemangiosarcoma, yes. Okay. Yes, they're going to appear at your door potentially as an emergency, and that will make a difference to your decision. Okay. There are lots of protocols for giving chemo post or for splenic hemangiosarcoma. They all have similar sort of survival times, so ranging from 130 to 170 days. Okay, so they're not brilliant. Compared to osteosarcoma, not brilliant. But your survival without chemo, does tend to be shorter. So if you're looking at a couple of months with just surgery, you're looking at, twice that with chemo. So say you've got, sometimes you'll get longer with just surgery, sometimes you'll get shorter, but generally speaking, you've still got a decent sort of amount of time. But the clinical stage for this is going to be important. So whereas I said with lymphoma, it doesn't really matter whether it's got stage 1, 2, 3, 4, whatever, with hemangiosarcoma, it would be worth doing a little bit more. And the staging, the sort of simple staging approach is to say if you've got a mass and it's just confined to one place and it's not ruptured, then it's stage 1. So say your dog comes in and you can feel something at a consult, at a vaccination, say it feels like it's got something in its spleen, and you scan it and you say, yes, it's got a big splenic mass, that's stage 1. Okay? And that's better than stage 2. Stage 2 is going to be it comes in collapsed because it's got a ruptured splenic mass. Stage 3 is even worse. That's when you've got metastatic disease, whether that's to other organs or whether that's to lungs. But that's going to be your sort of worst case scenario. Okay, and the survival times with chemo will differ depending on the stage. Okay, so if we remember the staging, so mass just in one organ, mass ruptured or metastatic spread. This is a little bit hard to read, but basically at the top there, first line is stage 1, and you're looking at survival time of 250, 340, 160, 260, 190, 193. Okay, stage 2, it's dropping down, and we're getting 190, 90, 60, 125, 117. These are getting not so exciting. And then stage 3, you're looking at 80, 60, 30, 60. These are worse than just doing nothing at all. Okay, so hemangiosarcoma is certainly not one that I would be giving chemo to every case. And yes, if I had a dog that came in and it had a ruptured mass, I would be thinking very carefully about whether it's probably worthwhile. Okay? But if it's one that's come in and it's been detected at an incidental examination and you've removed that spleen and it's come back as hemangiosarc, then I would be thinking about chemo, because they're the ones that potentially are going to get, 8 months, 9 months more of survival time. Okay? So I think take-home message for hemangiosarc is, it's probably a bit less optimistic, but still not something I would throw out completely. Right. Timing is everything. This is going back to your question. So, giving chemotherapy at the right time, relative to surgery, has been shown to be very important for lots of human cancers and also canine osteosarcoma, and also hemangiosarcoma. So, for hemangiosarcoma, we've got this time interval between surgery and chemo, what they're calling STOC, the surgery to chemo time. They're saying the best idea is to do it within 21 days of surgery. Okay, and your survival time, in the study they looked at this, they had a survival time of 238 days for those dogs that had it less than 21 days after surgery, compared to 146 if it was greater than 3 weeks after surgery. Okay, so if you're going to give chemo to your hemangiosarcoma dog, you need to get in there and give it within the first 3 weeks, or start it within the first 3 weeks. For osteosarcoma, there is a bit of a suggestion that you are even better to do it at 2 weeks. So I would say for both of them, if you can get in there between that 2 and 3 week period, that's when it's going to be most useful. So obviously they need to be healed, they need to be, recovered more or less, but you don't want to be waiting very long. Okay, so 2 to 3 weeks after surgery is when you really want to go in and hit them with your chemo, or start the chemo. Right, this is my slide to encourage people to use doxorubicin. Okay, so this is a little picture of people running away scared from the dangerous doxorubicin drug. Now, how many people use doxorubicin? So I suppose from a side effect point of view for doxorubicin, yes, it's probably more likely to cause GI upset. But is that dramatic and horrendous? Not usually, in my opinion. You'll always get some dogs that respond badly to anything that you give them. But generally, I say these are manageable side effects. So vomiting, usually that's something that is within 24, 48 hours. And if you give them 2 or 3 days of Serenia to go home with, often that will offset that quite easily. I've had one dog that would vomit whenever you injected the first mil of doxorubicin into its vein, and no matter what we did, didn't matter, did it? Didn't matter. We gave her Serenia, we did all these sort of things, and it didn't matter whether it had food or not had food. As soon as you injected the first mil of doxorubicin, it would be sick. After that, it'd be fine. So again, there's some odd things, but generally Serenia works really well. Or ondansetron is another drug that you can use for some that don't like meropitant. Diarrhea, again, usually happens a bit later on in the week, so 3 days, 4 days, 5 days afterwards, can be quite a bit later, so sometimes like a week, 10 days later. One study said that 40% of cases after doxorubicin had diarrhea. Again, I don't think 40% of the dogs I've given docs got diarrhea from what the owners said, but I say that was one study. But interestingly, after they had their diarrhea for the first dose, only 40% of them had diarrhea the next time. So, I wouldn't panic if they do have a bit of diarrhea the first time you give it. It's not necessarily going to be a continual issue. And you can use things like procolin or VBS clay. Has anyone used VBS clay before? No? That's something that's maybe worth getting if you're going to do some stuff with this. It's basically just a little pot of stuff, some sort of clay-based product, little powder. You get this tiny wee teaspoon in there, and the dose is like 3 teaspoons for a German Shepherd, and you think, well, what's that going to do? But it's actually pretty good stuff, and it's a lot cheaper than procolin when you're giving a big dog stuff. So that's something that you might consider. Having said that, in studies with it, they did find that 28% of the placebo dogs who didn't get anything it wasn't placebo then really, whatever not having anything is, got better with themselves as well. So a lot of these dogs, you give them stuff for the diarrhea, but a lot of them would just resolve. And I wouldn't use metronidazole, I suppose. That's one of the other things that used to be a bit of a popular choice, but nowadays, from an antibiotic point of view, I would probably advise against using metronidazole for diarrhea. And then extravasation, that's the big one for doxorubicin, and that's the one that I would say I am really strict about, I suppose, is that, if you have any suggestion or suspicion that you've put the line in or the IV and not got a clean stick into it, or you've sort of maybe done it but it didn't look quite right or feel quite right, then I would scrap that leg and I would move to a different leg, a different IV, a different line. I wouldn't push my luck at all in terms of saying, I think it's okay. I would just say, no, I'm not going to use that leg, because an old boss in a practice a long time ago did give doxorubicin to a dog, and it did end up with its leg getting amputated, and it was horrible. I always have dexrazoxane in the practice, so that's called cardioxane, is the trade name, and it is effectively an antidote to doxorubicin extravasation. But you have to give it within 3 hours of the extravasation, so you have to have it there on the shelf. I always buy it, always have it, haven't had to use it yet, but that's something I would recommend. If you were giving doxorubicin, I would just have it there, and you can add it to the price of a chemo protocol, and if someone who's unlucky when it needs renewing gets the price added to their protocol, but it has a fairly long shelf life. I don't know, like a year or 2 years or something. So, okay, right. Quickly, neutropenia versus sepsis. This is where the bit for those people that don't want to have anything to do with chemotherapy. This is for you, because even though you don't have anything to do with chemotherapy, you might end up have a patient who I've given chemotherapy come to you feeling unwell. All right, and if they do, one of the things you need to be thinking about is, are they neutropenic, or more importantly, are they septic? Okay. And the difference basically is neutropenia is just the fact that we've given it chemo and its neutrophil count has fallen, which is normal. It can fall to a certain level and we're not that bothered. It can fall much lower and we get more bothered. But basically they're often not, they're not poorly, they've just got a low neutrophil count. So that tends to be something that we find on a checkup. So if we were to give chemo for the first ever time, usually I'll ask them to go and get a blood sample at the referring vets a week to 10 days after treatment. If you take a blood sample and you get a result back and it says it's got a neutrophil count of 0, then rather than just emailing me back and saying it's got a neutrophil count of 0, we'll move on to the next slide to tell you what you're going to do with that. Okay? Sepsis is if you get a dog come in and it's ill. So it's a dog that's got cancer, it's on chemo, it comes in and it's sick. And it doesn't really matter how it's sick, it's just ill. Okay, so it might be being sick, it might have breathing problems, it might just be lying there looking miserable, it might be pyrexic, it might not be pyrexic. So again, you can't really be too specific, but I would say if any sick dog comes in that's on chemo, then it's worth just checking the hematology and seeing what its white cell count's doing. Okay, so if we've done our hematology and we have got more than 1,000 cells per microliter of neutrophils, so this is your neutrophil count, then generally speaking, that's okay. So it will be lower than your reference range, and depending on your blood machine, your reference range is either going to be 3,000 or 2,000 or 2,500 or something, but it will be lower than your reference range, but as long as it's above 1,000, generally speaking, it's okay. We wouldn't give it antibiotics, wouldn't tend to give it any more supportive care, as long as it's not ill. Obviously, if it's ill, then you need to treat it for whatever you think is going on. But in terms of neutropenic problems, that's not an issue. If it's between 500 and 999, then we would tend to give it oral antibiotics. Okay, so we're at the point there of where there's a risk of infection. Okay, there's a risk this dog is going to get an infection. So oral antibiotics, and probably the best one is TMPS. which again is a bit old school, but it's probably the most appropriate drug for most of the potential pathogens that this dog is going to get. Okay. Repeat the haematology in a couple of days, tell the owner to keep an eye on them, and generally speaking, unless they've got a temperature or they're poor or they're ill, then you wouldn't tend to do much else. If it's less than 500, and it's not uncommon that we see that, again, we go for oral antibiotics. If they are ill, if they've got a fever, then you're looking at your fluids and your IV antibiotics. And IV fluoroquinolones would be the number one. But we don't tend to give, again, the anaerobic antibiotics unless they're not responding to the fluoroquinolones. Okay, we try to keep the anaerobic medications away from them to preserve the normal gut flora. Okay, if we hit them with lots of metronidazole and other stuff, then it's a bit more of a problem. Having said that, there are some where we just think, well, this dog's really septic and it's going to die in 6 hours, and you just throw everything at them. And that's fair enough as well. But generally speaking, as a guide, this is what we're looking for. I've accidentally gone on to the next thing, but that's okay. This is like the boring bit I didn't really want to talk about particularly, but if anyone wants to go into it, you can. If you're going to give chemo, you can go away and have a look at what you need to do for that. You know, you need to get a bit of protective equipment, you need to get some cytotoxic bins. Consider sedation if the dog's not going to lie still. Yeah, there are some dogs where I just sedate them every time, just because it's safer and easier and simpler, okay? But yeah, if you're going to do it and you want to have more information about some of that stuff, then you can always email me and we can go into it. Final thoughts. Cancer is just another chronic disease, and I think this is a thing that I sort of say to owners a little bit, is that they have this idea it's got cancer, so we better just kill it. And, you know, the thing is, you know, dogs with kidney disease, dog with diabetes, dogs with liver disease, dogs with Cushing's, you know, they've all got chronic diseases that need long-term medication that are going to die quicker than what they would have done if they didn't have that disease. And cancer is it's the same. You know, it's just another chronic disease which we're giving drugs for to keep them going for a bit longer. And doxorubicin is just another drug. You know, it's not one that you have to use, but I would say if you do think about doing chemo, it's a useful multi-purpose drug that if you get used to it, you know, you may think, well, actually, that's not that big of a deal.